Sir, ma'am, have you got a notification saying got it?
Live stream, yes.
Yeah. It is showing that live streamed and all.
Could you please click got it on your respective screens?
Yeah, I have clicked it.
Yeah.
And it is showing live on the screen.
Yes, it is showing live.
Yes.
Okay. So welcome all. सेवासदनच्या सर्व प्रिय दर्शकांना मनपूर्वक स्वागत. आज आपण भुलेविषयी आणि भूलतज्ञांविषयी कार्य भुललासी असा जो आपला टॉपिक आहे थोडंसं जाणून घेणार आहोत. आणि मला खूप आनंद होतो सांगण्यात की आज नुसते आपल्या महाराष्ट्रातून नाही तर कर्नाटकाहून चेन्नईवरनं पण आपल्याकडे एक्सपर्ट लोक जॉईन झालेले आहेत. मला असं नक्की खात्री आहे की तुम्हाला याचा खूप उपयोग होणार आहे, खूप छान माहिती मिळणार आहे. For further course, I would like to change the linguistics to English and Hindi. Wherever possible, we will be translating it to Marathi, especially if there is some questions from the audience. So, my dear speakers, my experts, my teachers, welcome all. We are streaming this live session to commemorate the first ether anesthesia demonstrated by Sir William Wharton. And today, no doubt, since then, anesthesia has grown tremendously, has expanded to various branches. Superspeciality in anesthesia is upcoming now. And there is a much definite role for us anesthesiologists to play rather than just the anesthesia or BUL, as we call it in Marathi, in the operative theatres. So this year's theme focuses on mobilizing political will, education, and highlighting achievements of the global anesthesia community. So a round of applause for all the anesthesiologists who are doing wonderful job and who have done great in the COVID period also. We at Sevasadan are really fortunate to have internationally acclaimed anesthesiologist intensivists among us today for this session. Let me start by introducing our speakers. Dr. Balavenkat sir, definitely a name very well known across the nation and international waters for his contribution to the field of regional anesthesia and its development. He is a senior practicing consultant anesthesiologist at Ganga Hospital and also heads the academic department and the perioperative care unit. He was the founder president and now is the national chairman of Academy of Regional Anesthesia. He is served and also is an active member of numerous national and international anesthesia consortiums. He has delivered numerous lectures, orations, conducted workshops here and abroad, and has equally contributed to the research and development with papers in peer-reviewed journals. So welcome, sir.
Thank you.
Our next esteemed speaker is Dr. Chinnadurai, sir. He's a lead intensivist at Anaesthesia Hospital. After graduation from Stanley Medical College, specialization from CMC Vellore, he holds a European diploma in critical care medicine and has dedicated his entire 18 years of experience in critical care medicine. I would like to put it in here that he's a pioneer of driving organ donation and transplant program in Karnataka and has successfully coordinated more than 100 organ transplantation through the Jeevan Sarthike program. Sir, it is a real wonderful opportunity to have you here.
Thank you for the
And to add to our various branches, we have Dr. Vasudha Zadav, madam. She's the current president of ISA Sangli Miras branch. She's a full-time professor in Bharati Medical College, where she has single-handedly developed and promoted the pain clinic. She has received fellowships in international pain medicine, clinical rheumatology, cancer pain, and many others. She is a guide to 8 PG students till date and has 22 publications to her name and is an acclaimed socialist heading different organizations. Last but not the least,
thanks for introducing.
Thank you, ma'am. Thank you. You're welcome to join. Last but not the least, we have Manohar Mane sir. He's a young dynamic anesthesiologist, consultant anesthesiologist at Sevasadan. Also has a teaching experience as associate professor in Bharati Hospital. with more than 15 years of practice and handling independently cardiac neuroanesthesia complicated cases in a tier 2 city like Sangli, we would definitely have in Kitty his experiences of the various modalities. So without further much ado, I welcome again all my speakers for having contributed their time to us today. We start with the first question, and that too is for Bala Venkat sir. What has changed since the last decade in anesthesia practice? And that too, if with regards to patient safety, patient consultant interaction, and the counseling part of it. What would you like to see?
That's a very good question, Dr. Amrita. Actually, when it started, the anesthesiologist, many of the times, probably a decade back, they saw the patient inside the operating room. So they were involved only in giving anesthesia, and the minute the anesthesia was over, there was no relationship between the patient and the doctor. So now we have evolved. And I would like to say that the role of anesthesiologist in the perioperative care has emerged across the globe and more so in India as well. So what does this mean? The anesthesiologist, for example, a patient has to undergo a surgery. There is a surgical patient with multiple medical problems. I will take an example of a 70-year-old patient coming for knee joint replacement. He has undergone a bypass surgery earlier. He's a hypertensive, he's a diabetic, he's on multiple medications, and the surgeon decides to operate this patient. Now, initially they were referred to a physician, but now that chapter is over, and now they are referred to an anesthesiologist. So the anesthesiologist who is going to give anesthesia to this patient does the pre-operative clinical assessment of the patient, number one. Number two.
In layman's terms, sir, would you like to say that now the fitness for anesthesia, whether the patient is fit or not, is primarily the anesthesiologist?
It is not only fitness. Suppose he feels that he's currently not fit, he also gets into making them fit for the anesthetic procedure. So it is, number one is analyzing his current status, whether he will be able to undergo the surgery without any issues. And number two, if he finds there are some issues, he gives the corrective measures for that. So we call it optimizing the patient to undergo the surgery. So this is also the new terminology that has evolved, is called as, all the lay people will know, rehabilitation, which is done after the surgery. But now a new phenomena has come. This is called as prehabilitation. So before the surgery, optimizing the patient's physical condition to make him undergo the surgery, and the outcomes seem to be better. So that's number one. This has completely changed and evolved now. And number two, the role of anesthesiologist, apart from giving anesthesia, is extended into the postoperative period, because I think one of the single most important factor, a patient who comes for surgery is afraid of two things. Number one, whether he will get up off the anesthesia, whether he will be alive after anesthesia. Number two, whether he will have severe pain after anesthesia. And I think both the things, it has become extremely safe to do an anesthetic procedure, even in critically ill patient or patients who are very sick. Like for example, a patient with liver cell failure, where the liver is completely not working and he is going for a liver transplantation. Now, this also has become very safe because every second, all his parameters are monitored. So the intraoperative monitoring capabilities and the infrastructure has become better for the anesthetist. So every second, the internal parameters of the patient is getting monitored. So this is enhancing the safety of the patient throughout the surgery. And post-operatively, he contributes extensively for his getting back his internal physiology back to normal by giving IV fluids, because he may not eat. So they give fluids, they'll give pain relief, and they make sure that all the parameters are normal. And The high dependency units, many centers have got it. It is under the control of anesthesiologist who will look after the patient in this critical period and make them bounce back. So the safety component of critically ill surgeries has become very, very safe even in our country today. And it happened much more in developed nations earlier, but in India, everything that is possible in US and Europe can happen in this country today.
So that should be our take home message. थोडक्यात सांगायचं तर आपले बाला वेंकट सरांनी असं नमूद केलंय की अनेस्थेसियोलॉजिस्ट फक्त भुलेपुरता ऑपरेशनच्या भुलेपुरता मर्यादित नसून तर पेशंट आधी कसा फिट आहे, नंतर त्याचं ICU मध्ये किंवा क्रिटिकल केअर युनिट मध्ये त्याचं अॅनाजेसिया किंवा त्याचं पेन रिलीफ पण बघणं, त्याचं सगळंच रिहॅबिलिटेशन बघणं हे पण हल्ली anesthesiologist करतात, तसंच काउन्सिलिंग पण करतात. थँक्यू सर. That was a major change, I should say, from what you might have started as an anesthesiologist. Yes. So this was a question, sir, I was supposed to ask later, but since this topic has come up, Chinna sir, do you really think now that the perioperative care unit or the post-operative ICUs or the SICUs, as they call it, should be under the domain of anesthesiologists only?
No, it is not really, because it should be maintained by who has knowledge about critical care, either anesthesiologist or general surgeon, or general physician who have gone through critical care training, so they can manage very well. For example, our ICU, surgical ICU now, we manage the patient post cardiothoracic surgeries, post orthopedic surgeries, neurosurgeries, general surgeries, sometimes of the transplant also, renal transplant, liver transplant, lung transplants. We manage all those patients now. So surgical ICU per se, it is not only about giving only pain relief, either epidural or central morphine or fentanyl, any kind of pain relief. It is more than that. For example, now being anesthesiologists, we all learn 2 to 6 hours of intensive monitoring and care intraoperatively. That should extend post-operatively also, which we cannot give same intensity in the post-operative period. Always nurses taking care of more of these patients than the doctors. Here, doctors driven inside the OT treatment, whereas when we hand over to the other doctors and nurses, they are managing like an overall picture: ventilator management, your nutrition management, antibiotics, pain relief, DVD prophylaxis, everything comes. It is kind of critical care. So what I mean to say, it should be maintained by any doctor, any branch doctor who has knowledge about critical care should be able to manage post-operative ward, ICU, sorry.
So,
Dr. Amrita, can I add to
it?
this?
Yes, please.
Yes.
Though I partly agree with Dr. Chinnadurai, I like the question because from all that we need to do, the anesthesiologist is the best trained to get everything done. Because if you see, those who have completed their MD General Medicine and then coming into the critical care have not got exposed to several facets of the critical care itself. And whereas the anesthesiologist, everything that you want, they're getting trained as a part of their curriculum, getting a tracheostomy done or intubating the patient, and
so basically the emergency procedures part of it, right?
Emergency procedures, and not only that, and whatever Dr. Chinnadurai said, DBT, it's under everything can be done by them, and we are doing it. We have been doing it for the last 20 years. All our sick patients are looked after by the anesthesiologist in the intensive care unit, and our results are excellent. Right. So I just wanted to tell anybody can do it, but I think the anesthesiologist, because of the curriculum, I feel that they play a huge role right now.
No, so what, I just want to add this point. I'm telling you, the doctors who just completed, who have any branch of medicine complete 3 years of critical care training, then managing ICU, sir. So that those 3 years of training, anesthesiology, general medicine background, general surgery background, all will learn about critical care, then can be managed with them, I'm saying, sir. Not
Yeah,
immediately.
Yeah, I was
no,
coming to this next question for you, Chinna sir, the same question. As we now say that anesthesia is expanding beyond the routine,
Yes.
that is in critical care, pain medicine, advanced cardiac anesthesia, neuro anesthesia, regional anesthesia. So initially, in your career, from an anesthesiologist to intensivist, what were your challenges? And how has critical care evolved with anesthesia in this, whatever, 2-3 decades? So I suppose it will answer many of the questions why anesthesiologists and critical care go hand in hand.
Yes. See what happened when I finished my anesthesia training, and after that, when I want to jump to the critical care in 2005, 2006, when I want to jump to the critical care, there was always big question. Oh, this guy is anesthesia guy, whether we can manage this patient under him. Other physicians all had the doubts about, he knows about managing airway, ventilator setup, that's all, invasive lines. But that time there is no critical care training in India. The people have come from abroad, finished the training and started taking over, the slowly corporate hospitals, ICU. Always they were thinking, oh, this guy is from anesthesia background and this guy is a general medicine background. Who is superior? Who is inferior? All that, background talk was going on. But you see what happened, there's always be anesthesiologists dynamic to learn more and more quickly, grasp. For example, being anesthesiologist, I don't know anything about the infection control practice. I don't know about the infection management. Is it? So see what happened. I have to read and everything to acquire knowledge and discuss on par with the general physicians. General physicians sitting in OPD, seeing as a patient, coming with the symptoms. We never manage symptomatic management. Somebody comes with a fever, cough, cold. We never manage pneumonia, never manage liver failure, never manage kidney failure, all that. So what happened, there is a transition happened in late 2000, 2008, 9, 10. So more and more anesthesiologists going towards a critical care. There's some people, friends finished this, critical training from Australia, UK, and they started coming. We formed a slowly team. We learned medicine from them. They learned, anesthesia and, mechanical ventilation, all from us, so that we formed a kind of team. So as we attend more and more conferences, we understood about the critical care management, how to counsel the relatives, how to counsel for the death process, because there's a lot of death we see, in the OT, death is very rarely we see OT death. Sometimes the patient, even now the practice is, if the patient have a cardiac arrest, they don't declare an OT. They shift to ICU and manage for a couple of hours, then only they declare death. So being a critical care physician, we need multifaceted. So slowly I proved myself, I'm not an anesthesiologist, I'm the good physician too. So that slowly other people who come, for example, now I have to be a cardiologist now. I have to now, when the cardiologist walks in, they have to discuss in cardiology terms, So I have to on par with them. They're never now thinking that, oh, this guy only intensively doesn't know anything. So cardiologists discuss about their advanced treatment, pulmonologists discuss about their advanced treatment, neurologists discuss about them, liver, team, everyone discuss about their advanced, so that we have to keep improve our knowledge so that we are on par with them. See, now what happened, most of the hospitals now, they say, okay, for example, I'll tell you a classical example now. There is one senior anesthetist, his wife has a problem. He was admitted in ICU 3 days back. He is a senior anesthesiologist. He admitted, his wife was at many hospitals, but he is very particular. He won't get admitted under me only. The patient should be admitted under me. He doesn't want any other physician. When we shifted the patient after getting better to the ward, again he is telling, no, we want to transfer under you only. Let ICU team come and take care. Because now everyone realizing ICU team is not like anesthesiologists typically. They are kind of become general physicians now. Since the world is losing general physicians, we become like a general physicians. Now, there is no difference between anesthesiology, general medicine, all that. See now, but we see now 80% of critical care physicians are having anesthesiology background. Yeah, because we may have more empathy towards patient suffering. Why we choose the profession? We want somebody have a pain, we give some morphine, fentanyl, we say no pain, we are more happy, more and more happier. maybe we branch people are more empathetic so that we can success.
Thank you so much, sir. So, any of the panelists would like to add to this? Any experiences, any noting that anesthesia and critical care now evolving as a, two sides of one coin, as we can put it. So, I suppose we should take it forward, right? So, coming to the pain part of it now, ma'am, we have already heard that pain itself is such an entity that can cause pre-op, peri-op, and intra-op, many complications, issues, and all. So, I would like to ask Zadho ma'am that it is a relatively newer branch to be segregated from the mainstream
Yeah.
anesthesia, the pain clinic or the pain concept. So,
Yeah.
how would you like to enlighten us about it?
Yeah. If we go back to the evolutionary era, when Eva was supposed to be created from Adam's rib, he was put into sleep. So that way, anesthesia was the first applied science in the world. Pain was managed from the ages in different way by different people and different specialities. But as the technology evolved, new diagnostic technologies, radiological equipments new. So people are able to identify the pain generators and then blocking them. And because of that, more focus was on the pain medicine. And we being anesthesiologists are working with various type of analgesics daily. And we are also trained in various regional blocks, centrally, peripherally. So we are very well versed with the pain pathways. And we have a better understanding and orientation towards pain management. So I feel that anesthesiology is the base of pain management. Although it involves a multidisciplinary approach, like apart from pain physician, we need a psychiatrist, then a clinical psychology, then a physiotherapist, or sometimes orthopedicians. And the pain consultant, he has to have a knowledge of, means we have to study a lot about orthopedics, about radiology, about medicine, about rheumatology. So then only we can have a grip over the subject. During our residency period, we are not in touch with directly with the OPDs, only except apart from the pre-operative OPDs. So we have to learn that part also. But because of pain medicine, I think now we are not behind the curtains. It's not a branch which is behind the curtain.
Behind the curtains. So,
we can directly face the patient in the OPD. We can diagnose them. We can investigate them, treat them accordingly.
And give a
I
result.
think, yeah, that
And
gives us a public image.
Right.
So that is a good part. Yeah,
Right.
that's
So,
what that's my opinion.
right. So I know, or rather I shouldn't presume, I know and I assume that Bala Venkat sir is also a lot into pain management and pain clinic also. Would you like to add something, sir? So audio.
I think when the anesthesiologist incorporate the latest technique and technology, like the ultrasound guided block, when somebody undergoes a major surgery, when the tissue injury happens, when you block the nerve which carries the impulse from the surgical site to the spinal cord, if it is blocked, the chances of developing chronic pain syndromes later becomes very less. So the new concept of what we call it as multimodal analgesia, plus using regional site-specific analgesia as a part of multimodal, decreases the incidence of chronic pain syndromes which happen due to surgery. There are other pain syndromes, but then post-surgical pain syndromes can become very less because of proactive work of anesthesiologist in the immediate post-operative.
That was a very, what you can say, take-home message for all of us practicing anesthesiologists, how to use multimodal analgesia to reduce the post-op and chronic pain complications thereof. So coming to Mane sir, I would like to ask you that since you have been practicing anesthesia and you're doing cardiac anesthesia, neuro anesthesia in a tier 2 city, I would like to say that expertise is not an issue. Infrastructure may be, may not be. So what are your experiences about it? And single-handedly or independently practicing?
Just before starting the speech, I would like to congratulate Sevasadan Hospital for arranging this platform for the public awareness. And I would like to say happy World Anesthesia Day to all the faculties and all the anesthesiologists on the World Anesthesia Day, 16th October. Yeah. First of all, when I started in cardiac anesthesia, I was having a phobia in my mind that would I be able to do all these things, or with the support of the cardiac surgeon and the management of Sevasadan Hospital, it became a very easy thing. And actually, I think the cardiac anesthesia is based mainly on the that basic things of anesthesia, that the 4 pillars given by Lunde, that means unconsciousness, analgesia, hypokinesia, that is relaxation, and hemodynamic balances. If we are able to do that, that becomes the basic thing on which all the other specialties they have builded like that. So like neuro anesthesia and cardiac anesthesia, the basic thing is the basic anesthesia, general anesthesia. After that, then the cardiac anesthesia, there, no doubt there are some principal differences in the cardiac anesthesia, neuro anesthesia regarding hypotensive anesthesia like that. But the base is the main general anesthesia on which all the buildings or pillars are they have built it like.
So I would like to ask you in extension to this question, sir. Now we have a super specialty in anesthesia also, like critical care, cardiac anesthesia, neuro anesthesia. So do you think that a 3-year dedicated course for a cardiac or a neuro anesthesia would help, say, a PG student from anesthesia to do something better, or the work experience is the same sort of experience in anesthesia, working and learning, as you call it?
Yeah, as Chinna sir has already give answer for this question, that if more 3 years or so is given for the faculties like ICU or cardiac anesthesia, that is always better, no doubt about that. But in the cities like Sangli, it is not possible to have the anesthetist who have done DM cardiac anesthesia or DM neuro anesthesia. So right now at present, it's a job of the general anesthetist to get trained in the cardiac anesthesia and to start the job over here.
But no less, we should put it that the basic remains the same and there is no different whatsoever in the probable outcome of the patient.
Yeah, training would always make difference, but if it is not available, one can go with the general anesthesia only under trained for 1 year or so.
Right. So in short, I would like to remember an incident that I was told that in late 60s and 80s, it was the general surgeons who were doing cardiac surgery, who were doing tumor surgeries, brain tumor surgeries, and who were removing the toenail also. But then eventually it developed into a cardiac surgery branch, CTVS, neurosurgery, and the surgical MCH branches. So is it something that we are seeing in anesthesia also?
Yeah. I think Balasar.
Yeah.
No, I feel the more and more a person keeps doing a focused work, he becomes a real specialist in what he does.
Yes.
Intricately, he can perceive, and in fact, he will preempt, he will think this is what is going to happen next. And before something happens, he prevents it from happening. This expertise comes in only when a person keeps on doing the same thing again and again and again. And I feel that the way forward for the fraternity itself, if we need to get the best outcomes, we need to have people who are absolutely focused on what they are doing. So for example, I'm working in the orthopedic hospital for the last orthopedic and trauma for the last 27 years. I see a huge difference in me when I joined and when I'm doing today. When a 100-year-old patient comes with a hip fracture, with the ejection fraction, with a heart functioning moderately or minimally, nothing happens to me now because I exactly know what to do and make sure this patient walks out of the hospital. This, I cannot say that this can be done by a youngster. So in other words, it needs the wisdom, the clinical expertise, the skill, the current updates. And this happens only when you're focusing on something because it's become huge. I can't do a cardiac work now. I can't do a neuro work now because principally I'm trained, but I don't have that expertise of doing one thing very specific. So I personally feel that more and more specialization will result in better outcomes.
You are very true in that, sir. Wisdom and gray hair always have to be acknowledged and followed through. And that is for all of us here. There is, I don't think so, there can be another opinion in it. So that goes true for everybody. That goes true for everybody. So coming on to a generalized topic, sir, there was a question from the audience also. The general concept of anesthesia, the people feel that, as you said earlier, they are never going to wake up. And especially if the patient is in critical care or in ICU, wherein the chances of the patient in the recovery is very low. So how do we convince such relatives or such patient, or to tell you frankly, when the surgeon has explained a death on table risk or consent, so how as anesthetists the consent in these matter form, or how do we go ahead with it, or considering all the possible risks, how do we explain the relatives that this should be done?
Should I take it, Amrit?
So everybody can add to it, not a problem. So you start.
I think the more and more critically ill patient we see, the more and more geriatric patients we see, because now in India, seeing patients above the 80 years is very common. So the chances of the possible poor outcomes are very high. So it becomes very, very important that the surgeon tells that is one part, but the anesthesiologist, I think it's very important to assess the reserve of the patient, the comorbid conditions, and take the patient attender into complete confidence on the possible outcomes. And all that has to be mentioned in a written, informed consent on the possible expected complications. And I think it's truly crucial, and they appreciate. The patient attenders truly appreciate when we are open to them and when we tell all the possible complications. And we also tell them these are the possibilities, but we will make sure that we put all our efforts to see that we'll make the morbidity or the mortality not happen because of the technique and the technology. But it's crucial to inform and get the signature of a person or an attendant who is the caretaker and who owns responsibility for the patient. Always there is a challenge. You explain it to one person and suddenly the next person comes in and says, I never knew what was told. So that's another important factor in a day-to-day practice.
In India, where it is a joint family and the decision makers are somebody else not present in the hospital at that moment also, it might happen.
Video consent is another point to what we can add to the safety for the anesthesiologist, so that all the persons can know that we are having that video going on. That will help us.
Mane sir, I wanted to tell you, credibility of an institution is built over years. For example, it is not the video that matters, it is Mane sir who matters. When they have full confidence in you, they are not going to sue you at any point of time. When they've decided, they've come to you with full faith. So, for example, we do about 125 to 150 surgeries every day. And imagine taking videos, that many videos. All that I want to tell is, if we are truthful, if we are patient-centric, if the day and night doesn't make a difference, same care is given in the day and same care is given in the night. And when they perceive it, there is no need for a camera. There is no need for even a consent.
And a good communication also.
Yeah.
Good
You need to
communication.
tell. Yeah, that's what I told. You have to be open with them.
But then medico-legally, you will have to put it on the paper.
No, that's what I said. That's what I said. Of course, I said informed consent is very crucial.
Right.
But what I'm saying is the faith they have in you is more important than anything else.
So should I say that anesthesia is definitely going to have the glorious days, like wherein, like the patient chooses a surgeon, the patient goes to a place for the anesthetist.
It is happening. It has happened already.
And it will happen everywhere at all levels, I suppose. Right. So coming to this, sir, there is a question in a layman language over here that we have. I'll put it in the Hindi. ज़्यादा भूल दिया तो problem आता है क्या? So the basic concept in general population is ज़्यादा भूल कम भूल, खूब भूल कमी भूल, और ज़्यादा भूल से क्या problem आता है? So if you could, just take a moment to remove some of the cobwebs, it would help us a lot. ज़्यादा and कम भूल. Because many a times while maybe during the post-operative period also, while counseling, people, clinical people tend to say, थोड़ा भूल ज़्यादा हो गया, इसलिए थोड़ा देरी से बाहर आ रहा है, ऐसे. So how do you manage such situations then? How do you go about it?
So should I? Anyone is taking it?
No, continue, sir.
No, actually, to the lay public, as we said, that we have tremendously improved in our monitoring technology. And one of the things which will prevent this Jada Bhul is continuous monitoring of bispectral index. So this BIS monitoring has completely changed. For example, we do major spine deformity corrections for 7 to 8 hours. And exactly what you are going to give, the amount of anesthesia that you're going to give is continuously monitored. So you can explain to them that there is a machine that is available to show the amount of anesthesia that we need to give, and this even can be monitored. So immediately after the surgery, the patient, in spite of 7 or 8 hours, they can be awake within the next minute.
There won't be any more incidences of zyada bhul now.
Yeah, except though it's more, except there are situations where we monitor the depth of anesthesia, but we don't monitor their sensitivity to drugs. For example, we use opioids like fentanyl and morphine, and some of them, because of the pharmacogenetic component in the patient, are highly sensitive to the opioids, which you cannot see in the BIS. So this is only one small thing that I want to add, that there is a possibility that they may be a bit drowsy in the post-op, and that is because of the opioids that have been used.
So there is another question in the audience now, since we have come to the drug part of it. So Jadhav ma'am, could you like to answer this question? They have asked one, what are the types of anesthesia? And the second one was, what are the side effects of anesthesia?
Actually, it is better if regarding anesthesia, Bala Venkat sir or Dr. Manohar Mane, because I am not into anesthesia since 2-3 years. Totally pain. I am into totally pain management. So
anybody can
I
take
won't
this
be
question.
able
This
to
is
do justice
actually
to the
a
answer.
simple thing that what are types of anesthesia and what are side effects of anesthesia for the
In that
general
case,
population. Yeah.
in local language, if you would like, I would speak in local language because
Yeah, sure. Sure.
yeah,
Ma'am.
I think the local person who has asked it, right?
Yes, yes, yes.
या तर साधारण संपूर्ण भूल आणि जागेवरची भूल हे 2 प्रकार आहेत भुलीचे. संपूर्ण भूल साईड इफेक्ट असे भुलीचे कधी नसतातच. जे असतात त्याचा पूर्ण काळजीपूर्वक विचार करूनच भुलीची औषधं दिली जातात. आणि आजकाल तर सगळं इतकं प्रगत झालेलं आहे, मशीन्स एवढ्या चांगल्या आलेल्या आहेत की पूर्ण काळजीपूर्वक भूल दिल्यानंतर काहीही प्रश्न उद्भवत नाही. पूर्वीची गोष्ट वेगळी होती, पूर्वीचा काळ वेगळा होता. आणि आजकालचे भूल तज्ञ सुद्धा संपूर्ण ट्रेनिंग घेऊन आलेले असतात. त्यामुळे साईड इफेक्ट असे भुलीचे काही नसतात. जे असतात ते वापरलेल्या औषधांचे थोडेसे असर असतात की जे 48 तास 24 तास ते 48 तासानंतर संपून जातात. साधारणतः हे 2 ढोबळ प्रकार आहेत. आणि बाकी मग अनेक प्रकार असतात. एका हाताला दिलेली भूल, एका पायाला दिलेली भूल, किंवा अगदी 10 मिनिटासाठी दिलेली भूल. तेवढं डिटेल आपण जायची गरज नाही असं मला वाटतं.
Right. Thank you, ma'am. Question for Chinna sir. As a head of organ transplant program now, so can you give us an account of the role of anesthesiologist during the entire process of organ donation to transplantation? Just a gist of it, so that people also come to know what you're actually doing.
Yeah, see, just one little clarity, clear message I want to give. There is 2 separate teams. One is organ donation team, other is a transplant team. As per the Human Organ Transplant Act, so there should be separate team. So now I'm heading only donation team, where my other colleague take care of the post-transplant patients. But I will overlook all of them, but I won't put notes, I won't actively participate counseling of the recipients, all that. See, now what happened when I, in 2005, when we came out of, first time we started about this program of, brain death certification. It's very difficult. It is very less in India happening, and transplant rates success are much less in India at that time. So now, if you see after 2015, the transplant success rate has gone up to leaps and bounds. Now, survival percentage of any transplant, even heart and lung transplant, gone up more than 92%. So now more and more people are affordable, more and more people are undergoing transplants now. So we thought there is a huge gap between people need the organ and available organ. Because a lot of young people, they're giving them part of the kidney, part of the liver. Unfortunately, lung and heart can be given only for brain dead patients. So, but we have seen there is a huge potential. But unfortunately, not many takers towards this program, because it is very, very labor intensive. We need repeated counseling. Sometimes one organ donation takes something 20 to 30 counseling, different time, different people, they will keep coming, keep talking to them. As you know that, make someone understand about brain death, even for the doctors it's difficult. Make other doctor understand what is brain death. Just imagine about a lay person, somebody is a coolie, how to make them understand what is brain death. So we will, communication, education, all happening. Then we call more media, newspaper and TV media to, create a positive, message out of the organ donation. So now slowly we're inching towards more and more organ donation. I personally took in Karnataka, we have to improve the program, so that we started from 10 per year to 20, 30, 40. This year already we crossed more than 110. So we will reach 150 this year, 50 this year. So now government is close. I'm working so closely with the government. We educating more and more doctors. In fact, we took a lot of district hospital head and anesthesiologists. We also teaching them how to identify, counsel, communicate, and convert. So as anesthesiologists, as a critical care physician, I developed a lot of interest in organ donation. Once a donation happens, automatically plenty of organs available. So recipient team, transplant team geared up more and more. So migration of some of the international doctors in India happened. See what happened now. You can see the doctors, the lung transplant surgeon, leading surgeon in the world, one of the top 5. They're all moving to India. Indian surgeons who settled in abroad, cardiac surgeon, liver surgeons, lung surgeons are settling in India. Oh, huge opportunity in India to do more and more transplants, So that's what they moved. They also moved. Patient affordability improved. Organ donation happened on one side. All put together, we are having now, able to deliver this high quality of, the donor management plus, all kind of transplantations.
So anesthesia, I can say, is the backbone and growing big into organ donation and organ transplantation.
Yes.
That is what we can put it as.
Yeah, I mean, even intraoperatively, even intraoperative anesthesia is major role about, lung transplant, heart transplant, liver transplant, all superior, super speciality more and more happen in managing those transplants. The outcome is fantastic. Before, they used to do liver transplant when I was first to start seeing, they used to sometimes going on for 14 hours to 24 hours. Now the people are doing skin to skin 6 hours, heart transplant 6 hours, lung transplant 6 hours, liver transplant 6 hours with advanced anesthesia, advanced surgical technique. In fact, people are starting extubating on table. Extubating on table about post, liver transplant is amazing to see the advancement of our anesthesiologist technique and the quality of treatment.
That is wonderful. That is wonderful. And we will see more and more of organ donation and transplantations happening at every level, of medical care centers.
Yeah.
Right. So we have another generalized question here. If a patient refuses a particular type of anesthesia that is recommended, how to go about it further? Do you convince the patient for that type of anesthesia, or what do you do in such scenarios? Refused.
What I think is we have to tell the patient all the positive and negative things regarding the particular type of anesthesia. And then we have to convince again the patient that this is a good anesthesia for you, because we being expert in that subject, we can suggest the patient regarding which type of anesthesia the patient is actually needing. So convincing the patient and giving all the positive and negative things regarding that particular type of anesthesia is what I think is required in this condition.
That is yes, true. Truly, sir.
Right. So coming back to know our anesthesiologist part of it, now I would like to say that anesthesiologists are considered to be one of the vulnerable population among the medicos, doctors, us, for the burnout, for the stress that they handle. So I would like to know what our experts do to relieve that stress and the burnout.
You should enjoy your work, Amrita.
So
when you do enjoy the work, it's never a stress. Because whatever you do, if you do it passionately, it's definitely not stressful. The stress is in the mind, and when you think it is stressful, it becomes stressful. So for example, we work close to 16 hours a day for the last 27 years, and you've never felt that it is stressful. Because you have been able to contribute to somebody's well-being, and you're being acknowledged for that, and there's a sense of happiness involved in it. So I personally feel what people ask me. So people ask me about the burnout in working long hours. I think a person burnout is not the hours that he works, wherever he is. Suppose he goes home, if he's not happy with himself and peaceful inside him, even being in a house is a stressful situation. So I personally feel it is the personality of the patient and the happiness that he gets in getting things done. So
Yes.
burnout is something I think it's
Not
not
in your dictionary.
it's not in the dictionary, and I don't think it should be in the dictionary of anybody.
Right.
So I'll agree with sir completely. Yes, as you love any kind of job, every job is stressful. Even Prime Minister to Chief Minister to Minister, every job, every specialty have. If you think it's a stressful, is stressful. As you sir said, enjoy the profession and do that. It's not definitely. In addition to that, for example, now we critical care anesthesiology is different, where we manage more and more deaths actually. When we manage more and more deaths, actually, they will open up all their feelings, everything, which we sometimes take it through heart. See, initial days I struggled. Initial days what happened when I started practicing critical care. When they meet to manage a death, I go home and say, oh, for example, the wife is pregnant, husband came and died, and very small kids, husband died, they are on roads, we feel they start crying. We also human being, it affected so much. But over a period, I realized, I should not take it back home, I should not discuss at home. Then my fellow colleagues who come from all over England and other places that told me, China, we have to act as a drama, that, we have to take it, but you should not feel for it, so much feeling. You can feel a little bit, but not so much feeling. It affects you death process. We always struggle. Most of the doctor community, the lack of managing deaths actually. When the critical care physicians, when we manage death initially affects. That's what we train our younger generation how to manage the death, how to smoothen the death process. That is important. But always I feel we do the completely teamwork. One person cannot manage whole thing. Critical care is completely about teamwork. You just pass on, some other, next colleague, and you go home and sleep, peacefully. You should not get a call. This is about teamwork. I'm telling. Even anesthesia also teamwork. One senior, one. Nowadays, most of the OTs, when we started earlier days, one doctor only gives anesthesia end to end. Now we have a team of seniors, some trainees, junior, so that form is a good team. Complement each other. They just walk out on the corridor and come back. Otherwise, in the OT, the monitor's work maybe is very stressful. But more teamwork, as you sir said, more enjoy towards what you do. It gives,
Yes.
That way, I feel that pain management is means it is a very relaxed, I think, as compared to because it is very rewarding also, because patients literally touch your feet when they are relieved of pain, and you just enjoy it. It is very relaxing. 24 hours also you can work on it. That's what I feel.
So
after
it
working
is a
in
stress
pain
buster
management.
for Zadav madam, I suppose.
Yeah,
relieving
it
chronic
is indeed.
pain.
It is
But
stress buster.
how do you manage to convince them to undergo procedures on and on, so that their pain is relieved, so that the desired results is achieved?
Yeah, it is very. Before that, answering that, I would like to do one more addition of DMs in our anesthesia, that is DM in pain medicine. It is now there in AIMS and in some South colleges also. Yeah. So, I'll just give you an example. I had one patient referred from a neurologist. She had post-herpetic neuralgia of ulna now. She was literally on 1800 milligrams of gabapentin. She was literally dosing. She came to me, I evaluated. She was already investigated. I had given her stellate ganglion block. 90% of her pain had gone. That was diagnostic. So she was fully convinced for the therapeutic block. And with the second block, she was off medicine. So you don't need to convince. But yeah, there are some procedures where single shot procedure works. And there are many where you have to do first diagnostic and then therapeutic. So we don't need to convince patient if they have faith in you. And if you create faith in them, they get the results. Then it's very, very rewarding for the patients. So my patients, so they directly Google that. Sometimes they come to me and then they bring more patients with them.
That's fantastic.
So that way,
So
it's very rewarding.
That's very nice. That's very nice. So actually, we have only 5-10 minutes left now. I would like to touch upon two impending global topics, I would say. How about the role of anesthesiologists and climate change? One. And the next question would be, with this COVID pandemic ongoing also right now, and the biowarfare hazards that keep on impending, how should we gear up to the intensive care? So these are the two questions I would like the panelists to answer.
So maybe I'll take the pandemic part when Bala sir can take it for climatic changes. Because I don't use much, I don't use much gases now, so.
Let Bala sir change the climate.
No, about the gases, and I don't know. I mean, just you have to. Sir, your why your mute,
Yeah,
sir.
no. I think the climate change, as it's spoken across the globe, the anesthesiologists also do contribute to the climate change, and it becomes very important first to sensitize all the anesthesiologists that they need to change. And number two is, thanks to the advent of target controlled infusion and total intravenous anesthesia, he has completely changed the way we look at this. And now we have an option of contributing to the climate and making sure that our future generations get benefited by the acts that we do today. And one of the simplest of simple things is, which we have started doing, is the target controlled infusion, the specific infusion pumps which are available to do major surgical procedure. All that you need to set it up and say what is the plasma level that you want and monitor the BIS, and you are absolutely just oxygen. And we have the infusion of fentanyl and propofol or dexmedetomidine going in, and all surgeries can be done with this without any inhalational agents. And in this way, I think the future belongs to the TCI, and this is going to come up in a big way.
You're up to it.
So about pandemic, see now, anyway, initial days, when the first Wuhan, when that happened, we were all relaxing, it won't hit India, when the start hit India, especially second wave Delta, we have a terrible time. Your housekeeping, your nurses were running out, saying that our parents are not allowing to work back, so we don't have enough workforce. Then other doctor says, all other doctors says, it is not our field, it's between intensivists and physicians only manage it, we cannot come and help you. Then anesthesiology is also, fear of giving anesthesia for COVID patients. But this COVID taught us completely from end to end, from the top level to down level, great for workers. We should not run out of fear, and we can manage, and we learned and shown them. I think COVID taught us so that any kind of biowar happens in the future, we are mentally and technically prepared ourselves to manage. I don't think so. You cannot, you cannot have a same fear as before. I think we are more stronger now.
Right.
To add to this, Dr. Chinadurai, I think I always compare myself to the army person.
Yes.
When we are working 12 hours inside an AC room with such a nice weather, then you say that you are burnt out. Whereas whether it is minus 40 degrees or whether it is 55 degrees Celsius, an army person is protecting the country throughout his life. So naturally, he should be burnt out more than what we burn out. So it is only what yardsticks you keep to yourself determines whether you get burnt out or not. And number two, I think when you speak to an army man, he says that his country comes first, and he says that he would like to have the Indian flag on his chest when he dies. He considers it as an award. So they have been inculcated with that strong thoughts that their life itself is not very important. So I think the future generations, when we inculcate into them the patriotism and the need to contribute to the nation, and whether a biowar comes or For example, the COVID was, as you rightly pointed out, is a clear example of how the medical fraternity, especially the anesthesiologists, stood up to save several patients, and some of them lost their lives, but then we saved so many people. So all this is our learning points, and as we evolve, it becomes very important for us to teach the future generation, because I don't think many people will face the COVID pandemic like we faced. So the future generations have to be told about the hardships and how we handled it. This is a big lesson that we need to pass it on to them.
Yeah. One more thing I want to add, sir. So when I joined CMC Vellore, I really surprised, my HOD and, senior professors used to work even up to 7 o'clock, 8 o'clock. We finish our list and come out. They still sit and complete their list and go even up to 7 o'clock, 8 o'clock. Then I asked them, even any other branch in Vellore, for example, neurosurgeons, everyone. See, they clearly say we married our profession first, then only we married other counterpart. Where you love your profession, where dedicate towards our profession, any profession we do, I think that is what sir said, Army person dedicate his life to save the border, and we dedicate ourselves towards our profession to save many lives. Everyone has to do their part of their profession perfectly with the dedication, without the stress. I think that is the way forward.
Thank you so much, sir.
Anesthesia is more demanding than any other branches. Like day and night, you have to dedicate to your work.
It will be. Like we said, we should love what we do. So,
no, madam, and also it's a teamwork.
We have reached around the end of our session time now.
Sir wants to tell something. Please.
Yes,
No,
sir,
I said day and night is only when you don't build up a team. When you build up a team and you input protocols in place, the junior will do the same thing that you will do. So that's the way forward.
Sir, I want to say that is for the private practitioners, those who work, no?
Yeah.
They
Madam,
work
even private practitioners, now they've gone into group practice if they're smart enough, if they have the wisdom, and they go in for group practice. So they maintain their mental health and physical health as well.
So it was a wonderful session with lot of insights from our great experts today. I would like to thank Bala sir, Chinna sir, Zadav ma'am, Mani sir for such wonderful answers and insights into the lives of anesthesiologists, what they do beyond anesthesia, what is the future of anesthesia. I would like to also thank Sevasadan and the entire team for putting this together. And I hope our viewers have also enjoyed it like we enjoyed talking to each other. And I hope we meet soon for various other purposes. Thank you so much again, all of you, sir and madam. It was
Thank
great.
You, thank you, Amrita.
It was great hosting you all. Thank you, sir.
Thank you.
So thank you so much. It was a learning process. I learned from all the panelists and from you. And thank you for doing this. And thanks to Sevasadan for initiating this. And it's been a pleasure to be a part of it. Thank you so much.
Thank you so much.
Thank you, Amrita. Thank you, Sevasadan. Thank you, Sevasadan and team for giving me this opportunity to speak. It was a nice experience.
Thank you all.